All right. Well, good afternoon and welcome to the Integrative Care for Complex Populations Collaborative with Medicaid and Medicare. I'm Janet Herb and I'm your OHA liaison. Um, and is Walter and Jake available?
Janet, I am currently on. Walter's having some technical difficulties and should be joining us here in just a second. So,
Phenomenal. All right. Walter and Jake are your co-chairs, and they help set the agenda as well as I do. And so today for our agenda, I'm just going to read what's happening, and then we're going to go from there. Outside of introductions, we will be notifying you about a change of the chairs. Then we will be having our community-based palliative care for Medicaid members with guest speakers Barb Hansen and Linda D. Setter. We will have a 5-minute break for bio. And then we will have Care Oregon with Susan Yates sharing about equipment and best practices, and then public comment. As I said, this information will be recorded, and if there's slides or anything along those lines, I will be posting them as well. Any questions? Wonderful. Jake, you want to be Walter for a minute and talk about how there's been changes to the co-chairs?
sure, I think I need to work on my accent a little bit, but I think I can handle it, or at least my pronunciation and the way I pronounce things. So first of all, I want to just say thanks to Caroline, who was a member of our co-chair team. She has moved on in her career to a different job opportunity where she's no longer with Atrio. So in the long run, we wish her the best of luck in her future. And we do currently have the ability for anybody who is looking to participate in our Integrated Care for Complex Populations Committee. If they're interested in being a co-chair on this team, please email Janet, Walter, or myself. We'd be more than happy to meet with you, entertain the idea, and give you an opportunity to join if you would like. Back to you, Janet.
Thank you. We are now going to have our guest speakers, Barb Hansen and Linda D. Setter, pop on, and I will be controlling the PowerPoint, but I'll be sharing my screen. And just like Jake said, if you are interested in being a co-chair, please don't hesitate to reach out, and we would love to have you be a part of this team. Barb, Linda?
Great. Thank you so much for this opportunity to visit with your group. I'm Barb Hansen. And I'm an RN. I work with the Oregon Hospice and Palliative Care Association. Linda, do you want to introduce yourself?
I'm Linda DeSitter. I'm a palliative care physician. My latest job, full-time job, I'm semi-retired now, was working, I was the regional medical director for Providence's palliative care, running palliative care teams in 5 hospitals and multiple clinics and some home visitation teams. I now work very part-time, but I am also a member of the palliative care advisory committee for OHA.
Yes, I forgot to mention I'm also a member of that committee for the Oregon Health Authority. And you can go to the next slide, please. So this really just reiterates our background. I have worked in home health and hospice since 1985, so a very long time. And neither of us have any conflicts of interest to disclose, and all photos used in the slides are from Creative Commons and have not been altered. So we can go to the next slide. So Linda, this is one of your case studies.
Yeah, so we're going to use 2 case studies to kind of demonstrate for people who are less familiar with community-based palliative care, kind of how it works and how it's beneficial in multiple ways. So our first case study is a 64-year-old gentleman. He's has end-stage heart failure. He's currently homeless. He has a history of substance use disorder, and he has a high utilization and high symptom burden. Now, in his on his third hospitalization in 6 months, he is started on a medication called milrinone, which is an IV medication that improves your symptoms, does not prolong your life, but does preclude admission to hospice. So he would otherwise be eligible for hospice, but because of this medication to improve his symptoms, he is not. And the question is, how does community-based palliative care help? Next slide. The second case we're going to use is, and both of these are cases of mine over the years, is an
And
88-year-old.
these are not their real pictures. I should say
No.
these are from Creative Commons.
Yeah. Although the first person did give me permission to use his picture, but I never sent it to you, Barb. Sorry. So the second patient is an 88-year-old woman with dementia. She lives in a very rural area and is isolated. She's cared for by her elderly husband, who has high risk for safety issues and depression. The patient has increasing care needs, and the husband insists that he will care for the patient, and both children are estranged. The PCP calls palliative care, community-based palliative care program, because they anticipate an increasing disease burden over time and an increase in utilization, because that's the natural progression of dementia. So how does community-based palliative care help with this kind of patient? Back to you, Barb.
Yes, and we can go to the next slide. So we're going to give a very brief history about House Bill 2981. So an earlier version of this bill was introduced during the 2019 legislative session, and there was no opposition to the bill. It was introduced on the Senate side. We just ran out of time during that legislative session, and it didn't pass. So it was reintroduced during the 2021 legislative session as House Bill 2981. And it passed on both the House and the Senate side and was signed into law and technically became effective on January 1st of 2022. But rulemaking was delayed for several reasons, including staffing issues with the Oregon Health Authority. And of course, this was still during the pandemic. And I think everybody had staffing issues, so we certainly understand why that happened. And then draft rules were finally, they'd been issued before, but they were reissued in May of 2024, and comments were accepted until early June. And as of today, I haven't seen anything this morning, but Linda, I've been in lots of meetings. I don't think the final rules have been issued yet. So we're still waiting for the Oregon Health Authority to issue the final rules. And we can go to the next slide. So basically what House Bill 2981 said, and it's a very short bill, it's only about a page and a half, I think, is that the Oregon Health Authority will administer a program to provide palliative care services through the CCOs. And then in the rules would be determined the eligibility requirements and provider qualifications. And we will talk about those. So the qualifications really are that the patient has been diagnosed with a serious illness with a life-limiting prognosis, but there's no specific timeline. It's not like hospice where there's a 6-month prognosis. And this life-limiting prognosis negatively impacts their quality of life or the quality of life of their caregiver. And then the other main eligibility criterion is that the primary care provider, and it could be their own physician or another primary care provider, orders it, basically makes a referral for palliative care services. And these palliative care services must be provided in the patient's choice of residence. And the reimbursement was not spelled out in the bill, so that's really to be determined by each CCO and the palliative care providers. And Linda, do you want to add anything about this slide? And you are
No, I'll wait and give the comments about what
okay.
the community responded later.
Okay, you bet. And the next slide, please. And then from the draft rules, the interdisciplinary team, so like hospice has an interdisciplinary team. There's supposed to be an interdisciplinary team for palliative care. And the three core services are a registered nurse, a social worker, and a physician or primary care provider or specialty care provider. So that could be a nurse practitioner. I think it could possibly be a physician assistant as well. And then the interdisciplinary team may include one or more of the following different types of personnel. So there's a lot of latitude here: licensed practical nurse, nurse's aide, home health aide, hospice aide, community health worker, OT or PT, volunteers, spiritual care professionals, advanced practice clinicians, and then licensed mental health professionals. Um, and so there's a lot of latitude, and there could be different teams for each palliative care provider. They could have a slightly different makeup as long as they all have a registered nurse, social worker, and a primary care provider. And so we can go to the next slide. And then there has to be a written plan of care, has to be established for each patient. And the care provided has to be done in accordance with that plan. And the provider qualifications is that each CCO would want to credential whoever they're going to contract with to provide this palliative care service. And it could be similar to what they already require for home health hospice, or they may already have requirements for outpatient palliative care providers. And then each member of the interdisciplinary team is supposed to be trained or certified in palliative care. And there's a nationwide shortage, and there's certainly a shortage in Oregon of certified palliative care providers. So when the bill was drafted, the language said at least 16 hours of palliative care training. And then each palliative care program has to designate this interdisciplinary team who provide or supervise the services offered to the patient. And we can go to the next slide. And then in the draft rules, these were listed as what should be included under the list of palliative care services: advanced care planning, including a discussion about completing a pulse, but it doesn't require a pulse to be completed, and or an advance directive, just a discussion to see if the patient wants to complete those documents. Case management and care coordination, symptom assessment and management, transitional care management, behavioral health and social work services, 24-hour clinical telephone support. So that doesn't mean visits in the middle of the night, but a 24-hour support line, basically, spiritual care services, and then different aspects of education. And I won't read the slides to you. Hopefully you'll all be provided with a copy of these slides. And then we can go to the next slide. And then there are identified disenrollment criteria. If someone enrolls in hospice, then they would cease being covered by the palliative care service if they die, of course, or they're no longer enrolled in Medicaid and not enrolled under that CCO. If they have an improvement in their condition and they don't meet the eligibility criteria, and if there are unsafe conditions either for the patient or for staff. And if they don't want to be in the program, of course, they could disenroll. And if they move out of a palliative care provider service area, or they engage in behavior that causes safety concerns, or they live in a home where others are engaging in behavior that offers these safety concerns. And we can go to the next slide. And then Linda, I'm going to turn this over to you because you collected these comments. Well, you put them in themes, I guess.
Yeah, I think OHA collected the comments.
Yes, the OHA collected the comments.
Yeah. So OHA received 17 comments, and every single one of those 17 people was an expert in palliative care, and 11 of them were clinician and administrators who had already tried or were running at least one community-based palliative care program. So this is a tremendously experienced group that responded. And in it, we want to, the main themes, there were 6 main themes that came out of this. And I'm happy to share with people how I pulled out these themes. But the bottom line is that 14 out of 17 said that it was really important to have per member per month payments within the contracts between the CCO and the program. And many of the things that were cited was that the failure of previous programs, which were based on a fee-for-service situation. And I'm happy to talk about that if anyone has any questions. 14 out of 17 said, yes, we should require 16 hours, and that should be a minimum. 10 out of 17 wanted to add or change the definition of the interdisciplinary team, and the most common recommendation was to add a community health worker. You can see 6 out of 17 wanted to change or alter the definitions of eligibility. 5 out of 17 were very concerned about collecting significant metrics. And 3 out of 17 wanted to be sure that somewhere it was documented how often the interdisciplinary group should meet to discuss the plan of care. Next.
Linda,
Yeah.
Actually, can you go back to that slide for just a minute? Because Linda, I wanted to ask you where it said require 16 hours of training for core team members. That refers to the physician, the nurse, and the social worker, correct?
Correct.
But not necessarily for the whole rest of the team. In other words, if you were going to bring in a physical therapist, you wouldn't necessarily require 16 hours. That was going to be the suggestion there. And then the, let me see, collect significant metrics. Do you have any examples of what the metrics, like those were quality metrics, I assume? I don't know if you have any examples you could share.
Yes, quality metrics are critical, of course, but also critical are utilization metrics. So if you look at the literature, the way that community-based palliative care helps is they give patients and families better care at a lower price, and they do that by preventing unnecessary hospitalizations and ER visits and other things. But that's the main thing is that they take care of problems before they get to the point where a patient needs to call 911. So that's what the data shows. And I think all of us who have tried or have run a previous program know how critical it is to show the cost effectiveness of a program and would want to make sure that those metrics were collected.
Okay, thank you. And now we can go to the next slide.
So back to the case studies. So our 64-year-old gentleman with end-stage heart failure went home, and the community-based palliative care team coordinated between home health, case management, and cardiology. The social worker met with the patient every other week, completing advanced care planning, providing counseling, further exploring the multiple social issues. His severe breathlessness, which was what kept bringing him in and out of the hospital so much, was treated with opioids, initially prescribed by the physician and then titrated by the palliative care nurse practitioner, who increased their visits over time as the symptoms worsened. The palliative care chaplain was added once existential pain issues were noticed, and the social worker helped reunite the patient with his formerly estranged sister, who agreed to let the patient live out the last few months of his life at home, provided that the community-based palliative care team was there for support. When the patient became mostly bedbound, he decided his quality of life was no longer worth living. And with the support of our palliative care team, his sister, the home health team, cardiology, he transferred to hospice for the last few days of his life with his last bag of milrinone hanging. He died peacefully at his sister's house a few days later. Over 14 months, the community-based palliative care team cared for this gentleman in multiple locations, and he was never readmitted to the hospital, not once. All his symptoms, physical, social, psychological, and spiritual, were controlled in the community setting by the palliative care team. Case number 2, the palliative care team, this is a different palliative care team. The palliative care team is composed in this case of a nurse, a community health worker, social worker, and physician. They evaluated the patient and husband in their home, and they met with the husband and patient and explained what probable disease trajectory would look like and end of life would look like in a typical dementia patient. Most people don't know what the disease trajectory looks like in their given disease, and it's critical for them to know that so that they can kind of plan ahead and know what to expect. The community health worker visited every month to complete advanced care planning. The grandson was identified, who lived far away, was identified as the best healthcare proxy, and he was brought into the conversation. The social worker managed to get the grandson to visit and find the houseless uncle, which brought great joy to the patient and the husband. And over the next 2 years, they continued to visit. The patient was discussed at monthly IDG meetings, but her dementia worsened. She had multiple UTIs, falls, and infections, all of which were managed at home by the community-based palliative care team. Finally, the husband recognized that he couldn't care for his wife anymore, and the social worker helped him find a good location for her where he could visit every day. And a year later, she has her first aspiration event, which is also normal in dementia. There was another family meeting, another discussion about whether she should be sent to the hospital or not. The grandson and the husband decided that no, they wanted to keep her there and do treatment there in the facility. But this prompted a referral to hospice. She was on hospice for 10 months and had 4 other aspiration events and finally died very peacefully there. In over 3 years of the community-based palliative care team taking care of her, she had 0 hospitalizations. Any questions about these cases? Okay, Barb.
Okay, we can go to the next slide then. And it's really just an opportunity for any of you to ask questions about the language in the House Bill 2981 or in the draft rules. Again, we're still waiting for the final rules to see if some of the comments were incorporated into the final rules. We're, I guess, waiting with bated breath, huh, Linda? And if there aren't any questions, we'll turn the time back over. Oh, do we have a question? Oh, yes.
One from George.
Yeah.
Go ahead.
Yeah, hi, George.
Yeah. Could you tell me what the definition is to that long word you guys were saying?
Interdisciplinary, or I'm not sure which.
It was in the bill. I think it's
Palliative care? Palliative?
Yes. Yeah, that one.
Okay, great question. So palliative means dealing with symptoms and quality of life. This specific bill targets people who are frail and probably in their last couple of years of life. Does that answer your question?
It does.
Thank you.
Great question. Thank you. Anybody else? And Linda, I see a comment.
I have a question.
Thank you for sharing the case studies. So good. Go ahead.
In other states, are there other states that have this written into the bills. How has this helped keep down the cost of hospitalizations across the board? The cost benefit of it. I mean, I'm hearing from what you're telling with the case studies, and it sounds wonderful. But do we have a bigger spectrum of the impact that it has financially
Well,
for the hospitalization?
California implemented palliative care as a Medicaid benefit in 2018, and they have found that it decreases emergency room visits and hospitalizations. And Linda, I don't know if you have more information about what's happened in California. Hawaii just implemented it, or it's just going into effect in Hawaii. So Oregon will be also sort of on the cutting edge by offering this care. But Linda, again, I'll defer to you. I don't know if you have any other case study or you can cite any studies or financial information.
Yeah, so there's been all over the country, people have tried to implement community-based palliative care programs, and there has been a wide variation of what has been tried, and wide variety of costs and wide variety of metrics, outcome metrics, including cost of care. I think most experts would agree that you really need an alternative to calling 911. And you need home visits for this frail population that finds it really difficult to get to the doctor's office in order to really impact hospitalizations. So there are a lot of different studies. Most of them are kind of academically oriented, so they don't have an N of an entire state like California does. But Barb is right. They're finding savings. The savings varies according to the robustness of the program. So if there is not enough per member per month outlay, you're going to end up with just phone contact, which is really not enough to keep people out of the hospital over a long period of time.
And then just a quick follow-up, if CCOs are, they have their own palliative care, but they want to make it more robust, who can they talk to, or the pros and cons of changing a template that they're going by? Who would you suggest that they reach out to?
That is a great question. So I'm going to sort of reverse your question a little bit, because once we have the final rules, I'm going to be reaching out to the hospice programs around the state, and there could be other programs who decide to offer this service, could be home health programs or primary care providers, federally qualified health clinics could provide this service. And they will be reaching out to the CCOs to say, could we talk about contracting to provide this service? So, and CCOs could do outreach to different providers in their areas to say, hey, we want to contract with some palliative care providers. Is this something you would be interested in doing? So Linda, I don't know if you have other suggestions that way.
There are some people who are doing this very successfully. I don't have permission to share their name and their phone numbers. But certainly, if the Palliative Care Advisory Committee is looking at how we provide better resources, as is the Oregon Hospice and Palliative Care Association. So I think resources will be coming, but we need to see the rules so we know what we're talking about.
Yeah, we don't want to get the cart before the horse, so we feel like we need to see the final rules before we can educate palliative care providers about what they need to do.
That seems very reasonable. Thank you. George, go ahead.
Yes. Do you know if Arizona has the same thing?
I've seen several studies of from Arizona programs, but they do not have the statewide program that we're talking about here. Good question. Yet, we'll see.
Yeah.
Okay.
Thanks, George. Anybody else have any other questions for Barb or Linda? Going, gone.
Well, our email addresses are on the last slide too, so we welcome any emails, any contact from anybody who has questions. We're happy to take those. And again, we thank you for this opportunity to talk to your group.
Oh, thanks for coming. A great
Yeah,
presentation. Aside from the metrics and all that stuff, it also tugs at the heartstrings. Thank you.
Oh, yeah, you bet. Thank you. Bye-bye.
Okay, so we're actually ahead of schedule by about 9 minutes, but I do think we want to take a quick 5 minute break, Shannon? Yeah?
Yeah, let's do it. 5-minute break.
Okay, 5 minute break, and then we'll come back with our friends from Care Oregon.
All right.
I'll,
See you.
I can hum like a theme song or something for 5 minutes if you need.
Oh, Lordy. If you all want to be a part of this team, just email me and you get to hang out with Walter humming all along. We'll be back about 1:40, and then we'll start Care Oregon. Thank you.
If anybody needs me to mute Walter, let me know.
Hi, is Susan on at all? Susan Yates?
Oh, I'm here. I couldn't find the unmute button. Janet.
Oh, no, that's perfect. I just know since we're a little ahead of schedule, I didn't want to assume that you were here yet. So I do appreciate you being available.
Sure.
And I have your PowerPoint, and I'll be the one that gets to guide it. So just let me know if I'm doing fast enough or not.
Thank you.
Of course.
$140. Kick it off.
Such a great leader. Thanks. Welcome back to the Integrative Care of Complex Populations Collaborative. And I'm very excited for this next presentation as it is an ongoing part of this group's wanting to start a bigger collaborative of what's working and what's not across the board so we can better serve our members because that's why we're all in this, is to serve people. And I will start sharing the screen, but Susan Yates Miller is here from Care Oregon.
Hey, thank you. As you load the presentation, I want to mention that I have some of my colleagues attending the session today, and I would invite anyone from Care Oregon and attendees to stop and ask me questions as we move along through the presentation. You don't need to hold them to the end. Okay, so today I'll be presenting a little bit about the background of our population, a little bit more about Care Oregon's population, talk a little bit about how we work with our network and some of the unique needs that we experience as a DSNP plan. And then we're going to move into an overview. We've selected 3 measures to talk a little bit about how we meet those measures and a little bit about the complexity surrounding data collection in general. So hopefully you'll learn a little bit about our plan and some of the different ways that we navigate both the footprint of the member and the complexity of our healthcare system. So I want to begin with talking a little bit about our population. So our Medicare Medicaid dual population sits at 17,683, and we watch that climb every month. We've been in a growth trajectory for the past few years, and that equates to about half of the DSNP members in the state of Oregon. We are in 6 service counties, and I've listed them here for you. It's in the Southern Oregon, Jackson County area, Metro Portland, and then over in the Columbia Pacific region. And for chronic conditions, thinking about what we know about dual members, many of our members have multiple chronic conditions. I think we start with 4+, and depending on the member that we're working with, it can reach up to 7+. Complex social risk factors and multiple medications. And what I want to point out here is Care Oregon, we use a tool to predict high cost and utilization to help us, plan our resources. And 60% of our membership does fall in that category of a probability for high cost. Next slide. And when we lean in a little closer to the population profile, so the model of care, which I think most of you might be familiar with, so this is a requirement of all DSNP plans that we have a model of care program. And what this is the framework or description for how we identify and will serve our population. So within the model of care, again, we have different forms of identifying our population and understanding a little bit more about who they are, some of the unique characteristics that they might bring. And then this helps us determine our benefit and our design. So we gather together as a group, we study data and understand patterns, and it does influence the benefits that we offer our members. And additionally, some of the internal and external resources that we allocate. So, combining the medical side, the social needs factors for our population, is paramount into our plan. And so some of the items that I've listed here when we think about, lack of resources, diminishing cognitive and physical ability, being in a constant state of fight or flight, generational poverty, and lack of healthcare and fear of the healthcare system. These are, again, some of the different characteristics that we have to consider when we're thinking about the different systems of support and special needs that we want to provide, special needs help for our members. So next slide. And go back one more slide, Janet, if you would. I want to just also talk about some of it's like the unique position too that Medicare Advantage offers us. And when I talk about benefit design, I want to be a little bit more specific here, because you'll meet many different D-SNP plans across the country, Medicare Advantage plans. But one of the things that we, I think, take pride in is understanding through current and updated data collection, really the needs of our members, as far as we like to consider the transportation needs. We provide a care card for our members where they can choose to buy healthy foods, meals after inpatient admissions, home visits for those that can't access for different reasons, the network and in-person visits. We have a program called Papa Pals where it fulfills needs for the individual, like driving to appointment, helping to make meals, and just companionship for those that are isolated. And we can provide more detail. It was kind of a high level slide here. Next slide, Janet. One of the other things that I want to talk about is, in our journey of working with our network and getting to know the different barriers and just profiles of each of the clinics and health systems and how we can, meet them where they're at for partnership. Thinking about one of the things that we've noted is the payer mix in the market, and thinking about with the clinic in the middle, the different complexities that presents for our payers, for the clinics, and thinking about the support that's needed for providers to have an understanding of all the different benefits and the unique qualities that each health plan might offer. And so we are noticing this, I think, especially after COVID, that there's some erosion of the resilience of the network. So they're taxed. And studying CMS data this last year, the most recent STAR year, we had Oregon had the lowest number of 5-star plans in the country. And this was a huge drop from the year before. So we had a decrease, I think a 58% decrease in the number of 5-star plans that would offer a Medicare Advantage plan, not necessarily duals, but a Medicare Advantage plan in the state of Oregon. And the other thing that's quite unique too is that we have federally qualified health centers in the mix here. And so when you have FQHC that serves, a number of different complex individuals, and then we're adding special needs on top of that, where with FQHCs, many of our members have multiple community-based organizations in their life, different agencies and multiple specialty providers. And so it does add, an additional, I don't like the word burden, but complexity for our FQHC partners. And then the other note from our network that we want to share is, in the grand plan, we would like to have alignment someday of measures. The STAR measure set this year for Medicare has 42 different measures. And we do look to our network to help partner and improve those measures with us, and thinking about the complexity of CCO metrics and then all of the other Advantage plan or partners. It becomes difficult for health plans to make distinctions about performance and really where do they prioritize and where do they start. So next slide. And somebody will have to let me know if there's a hand or a chat in the question. So what we want to talk about here is we have different tactics that we use at Care Oregon to engage our network. And again, back to the issue that we have FQHC. So meeting our partners where they're at. We do have other health systems as our network partners as well, but predominantly majority of our Care Oregon members will be assigned or receive services at an FQHC. So when we think about challenges with economy of scale, so low DSNP members in Oregon compared to other regions. I think that there's 30 other states that have more duals than we do in Oregon. So thinking about, when you build programs and you have workflows in clinics, thinking about any time that there's a complexity and you have to think about varying a program or offering something different, that's of consideration that we point out here with our network. So some of the strategies that we think about is, our duals, our members, they require multiple systems working together to coordinate their care. And there can be challenges, for some of the clinics to manage this. And so similar to, I think, Janet's comment just a little bit ago, best practice and bringing together our network partners to form a collaborative. So what we've done is our strategy is we do have value-based design at the heart of our work in Medicare. I think that we are about a year into our new program. And so the value-based design does help our network partners focus on specific measures that may be more complex, that need more coordination, take a little bit more effort to fulfill. And so we bring together a collaborative of our value-based partners, and we do share best practice to help support some of those, the trickier services and care coordination needs. One of the things that we have seen recently is some of the practices or health systems do a really good job of maybe collecting population health data, and then in turn really helping their providers to have current data to monitor and fill those gaps in a timely way. So bringing some of those best practices together has been really beneficial for our network. And finally, we do have incentives for our providers, financial incentives, and we have built in a reward system for our members. So what we have is kind of that the dual incentives there, where the network understands that they need to fulfill a timely access to quality care, and then the member understands, hopefully we're making it simple that they can access care in a timely way. And next slide. And then when we think about reporting our measures, so I mentioned that Medicare requires that we submit, I think it varies, but we have about 42 measures this year. And the data is complex. It's like if you think about the footprint of where the member goes across multiple different systems, and it seems like we're always chasing data in quality. And I would say that that's very true today. When we think about, it's taken a few years to get values on our data, and we're still struggling to do that. And so we, again, go back to the network and we educate about coding and letting our partners know about what data we need to help fulfill complete measurement for CMS. And so some of the, and this is simply just meant to, I think, call out the uniqueness of some of the measures that we report, but they are, when we call it the higher standard, we mean data, that it's a little bit more complex than some of the measures in the CCO data set. And examples of that, we'll talk about that. Andrew will talk about the health risk assessment in a little bit, but that's an example of a measure that, I think that, Andrew might say we have 4 or 5 different data sources that we use, or probably even more. So really a little bit more complex. And then lack of measure alignment, again, I don't have to go into too much detail there, but that does also cause, abrasion with both the member and the provider. And also, if we have a hard time explaining the complexity of the measures, you can understand how providers that are have multiple patients a day, not a lot of support for care coordination, to have an understanding of some of the measures that we produce. And we did choose one of those for you today, and that's the health risk assessment. And also, we really rely in our DSNP plan on a lot of vendors and community-based organizations to help fill the gaps. And so again, every time you're adding a layer of support, whether it be a home vendor or meal support or transportation, it then again adds a little bit more of a challenge to collect that data to present the full picture of services that our members are receiving. And then finally, in the network, we do help with having an understanding of coding, because again, that will tie back to higher reimbursement, which higher reimbursement will lead to richer benefits for our members. And next slide. And so just one final slide before we jump into the metrics today. CMS versus OHA. One of the things that we like to share with even our internal partners that work at Care Oregon is oftentimes when we think about the CCO metrics, we have OHA and different work groups that help with questions and maybe pointing the way to best practice. And in the world of CMS with Medicare Advantage, we don't have many of those groups that come together that might help with helping to answer questions about some of the complexity of new measures. And so there's a lot of time spent internally with different alliances that we belong to help streamline and these performance measures that we in turn work with our network to make it as easily digestible as we can. But again, there's a lot of challenges with some of the Medicare Advantage measures and just explaining them. They're not always easy for us to understand internally, so challenging to support internally and externally. And there's a lot of administrative effort again when we think about all the vendors that we might need to add for filling some of these different spaces and gaps in care that we have. And then finally, when we just think about any alternative measures, the cost of that. And I know that the Oregon Health Care Authorities had, we call them homegrown or alternative measures in the past, but CMS also has measures that aren't in an NCQA data set that might be in the public domain, some patient safety measures or the HRA. These become a little bit more difficult administratively to explain to providers, but once we get them on board, they can become great partners with us. But again, that complexity of those measures. George, I see you have a question.
Yeah, in the PowerPoint, I think it was number 6, page 6. It stated that rent was included in with the DSNP. I was going to ask a question. What part of the rent is included in with the DSNP?
So so it's not included in the DSNP benefit, George. It's provided as that is some of the data that we receive back from our providers when we complete our assessment, that's a insecurity or a gap that they have trouble paying rent. So financial insecurities and as well as food insecurities, transportation, housing, those are all areas that we collect at least annually with our members. And so I won't talk more about, the Medicaid benefit or what might be coming in the future, but for now, it is a referral that would go into our care coordination team that what we do is we try to help connect our members to resources in the community to either help with any financial issues or housing. Thanks for bringing that up, George.
Yeah, I was just curious. That was the first thing that when I saw it, I was like, wow,
That would be nice, huh? If we could just, yeah. Okay, so next slide, Janet.
Susan,
Yeah.
it's Walter. I just wanted to point out that Jennifer Valentine had posted, I'll call it a question in the chat. I can read it, and maybe this is something Andrew might be addressing. You can decide, but I'll read it.
Okay.
Care Oregon, hope you can share your quadrant for most vulnerable from your current FBDE TQS projects and the types of quality measures you are tracking.
We can follow up with yeah. I mean, I think that there are probably other people at Care Oregon that can supply outside of this meeting more information with that. So a takeaway for us. Andrew is my partner at Care Oregon and works as the population health quality manager. And he's put together a few slides to talk about the health risk assessment. And again, this is a unique requirement for DSNP plans in all across the nation. So this is a common, I was going to say, challenge for all of us to collect this data. Go ahead, Andrew.
Thanks, Susan. Good afternoon, everyone. It's fun to come talk to you today about health risk assessments. If you want to go to the next slide, I'll kind of kick things off here. The health risk assessment at Care Oregon, aside from the STARS measure and the requirements that we have to do contractually and regulatorily to conduct health risk assessments, we also really honor what the member is telling us in this document, that they're being vulnerable with us. They're sharing us about their health information. And it's a critical source of information that we, as a health plan, don't really have a direct source for. We can look very generally at census information and things like that, that talk to us about these these factors in a person's life that contribute to their health, but that we don't really have structurally functional solutions at a large scale for these issues in our traditional US healthcare system. So we kind of have to go around it. So we really, really appreciate what the HRAT anchors in terms of telling us about our population. If you can go to the next slide, please. Okay, so if I put on my hat kind of as like an operations person, a quality person, and if I had to leave you with any takeaway from my presentation today, this is probably that slide. As Susan alluded to, our HRAT data is really an amalgamation of 5 different current touch points of where an HRAT can be completed, plus all historical information back at least 10 years, depending on the regulatory body or element that we're trying to address. So in the case of a CMS program audit for Part C, what would come to care coordination around HRATs is completion dates as far back as 10 years, for example. You can just think about the amount of data that's just sitting in this warehouse that we collect as a part of the HRAT, and that has to be just stored and then accessed in an efficient way. And as no surprise, I'm sure, it's a giant mess. Our data architecture is all over the place. I think Care Oregon has done a lot of really good work, especially the last 6 to 8 months in maturing and evolving its IT and information services bench strength. We've had some really great people. I think we have some really clear leadership in place, and I'm really starting to see the depth of the analyses that we can do using our data now that we are encouraging to see now that a little bit more of our architecture is helping us collate that data together. As it relates to HRA, I developed a couple of, I'll call them guiding principles to help us ensure that the HRA that we're implementing or redesigning or whatever litmus test we need to do, whatever change we need to make with this HRA, what are the things that are going to make it a good product and a good process? So number one, it's got to be usable. It's got to be simple and clear and readable. Somebody has to actually want to take time to fill it out. And it has to be convenient for them. So we really tried to keep the assessment short. Our new version is only 20 questions long, and a really, really frequent conversation I had to have with a lot of stakeholders in developing our newest question set was people wanting to just dump everything into this health assessment. It's a convenient thing. It seems like low-hanging fruit at a technical level, and in some ways it is. Care organs, I think, draws a compromise. We have some questions that help us direct referrals around specific issues like pharmacy or dental needs. And we even have a HEDIS measure that we're helping meet by including a couple of questions on the question set. But ultimately, it's about the member, and they've got to be able to fill it out. The second guiding point is really connected to the third as well. We recently implemented Epic, and that's allowed us to make it much easier to get rid of our homegrown questions and adopt these nationally validated questions. That's also partly pushed by the new SDOH requirements that went into effect this year to include questions on transportation and food insecurity and housing instability. We want to make sure, again, that like if the member is going to be vulnerable with us and they're going to share this information with us, the question should be measuring what it's intended to measure. It should be validated and clear, and everyone agrees to it. And we're able to implement those things into our designs faster if they're pre-built in Epic. And Epic calls those pre-built things flow sheets. The last guiding principle is just like, it's got to be actionable. Again, like we've done all this work to make sure that the member fills it out, that they feel comfortable, that they're sharing with us, that we can use the information. But if our care coordination team, which is our main consumer of this information, for like internal referrals to our care coordination team, like if it's not really useful for them, like what are they? It kind of falls flat. So one example of this is actually one of our HEDIS related questions, our pain related question. We changed the wording of that question to be able to make it more, have more substance to it. Okay, next slide, please. So I'll pause here for questions kind of after I go into this. Probably no surprises here as well. Like once our information comes in, it informs so many things because it's a rare piece of information, because it's hard to get as a health plan, because our completion rates aren't 100%, they're getting better, and we'll go into that on the next slide a little bit. But when it comes in, like we really want to make sure we use it, not just by care coordinators, we use it to for benefit design. Our group talks about HEDIS and STARS measures, and it feeds, it informs our equity targets as well. So it really, it touches so many things in the organization. It's a really great tool. Okay, I'll pause here for questions. Is anyone?
Andrew, there's a question in the chat.
Oh, great.
Question from Jennifer. I can read it.
Yeah, I think, Jennifer, as far as duplication goes, Care Oregon has approached this as having one assessment tool for both Medicare and Medicaid. So we find some efficiencies there as well. In terms of members doing them multiple times, again, it's all about good data in, good data out. So the issue we struggle with is documentation of all the outreach attempts and documentation on different systems. So it's challenging for us to create a report that definitively says, yes or no, this member has a qualifying completed HRAT that meets the STARS definition, so that we can count it toward that, and it'll help that goal. It's just really complicated. There are internal efficiencies we're finding just in process and kind of like operationally. That's very internal, I guess, and like sort of specific to Care Oregon. If there are additional elements, to your question I haven't addressed, feel free to. You have my email. Feel free to contact me. We can talk about kind of where we're going. Yes, George.
What is HRAT data?
HRAT is just an acronym for Health Risk Assessment Tool. HRA, HRS, all synonyms. And so by data, we mean however the members' responses are gathered, whether it's through paper that they mail back to us, whether it's on the phone. So like someone in our call center is typing in this member's responses into Epic, our care coordination like software, whether they fill it out online through the member portal. All those like individual answers, like my pronoun, I'm Andrew, my pronouns are he, him. Like my preferred spoken language is English. On. All those like individual little pieces are getting stored in our enterprise data warehouse. And so that's kind of my broad umbrella by what I mean by like HRAT data.
Okay, thanks.
For sure. Jake.
Yeah, just a quick question. When you look at your HRAs, and I may have missed it, but what percentage do you receive back compared to what are sent out? And what pitfalls do you see that can be mitigated in that realm?
Yeah, response rate, I think for any survey is really tricky. Our Medicaid rates are usually around 30 to 40%, and our Medicare rates are usually around 50, 60%. I don't know, Susan, if we're allowed to share what our STARS rating was from 2023. I think we were at, okay, I think we were at 56%.
Yeah, so we've been moving up a point every year, and last year you moved it up about 7 points. So those internal efficiencies that you've talked about, I'm beginning to see that in our STAR score.
Thanks, Susan. And then Jake, in terms of like boosting those rates, Susan mentioned how do we sort of the internal work that we're doing. Part of that is really pushing outreaches to get within that 90-day completion time frame. We have a lot of completions that happen outside of that time frame. So internally, we kind of track that as like great, like we completed this HRAT, that's important. But in terms of CMS, if it's outside of that 90-day window before or after your effective enrollment date or before your annual HRAT due date, if a completion happens outside of those time banks, you can't count it toward your STARS measure. So really trying to get efficient on our call center and have them have the logic behind their work list like really be strong so they can make those calls. The other thing I'm really interested in working on over the next few years is squeezing the rest of the juice out of response rates. I think we're probably reaching at sort of the natural, normal responses. Like our response rates aren't uniquely high or low compared nationally. I think there's a lot we can do. I guess if you want to go to the next slide, this kind of feeds into that. It's my last slide. Kind of like where do we go from here? And so a big part of it obviously is completion rates and response rates, as I said. I would love to like get a bus and park it in a neighborhood where a lot of our members live, and like go like be at a park and see who shows up. Go door to door. I think phone calls we've taken that about as far as it can go. So innovating new completion routes or completion events, things like that, like being able to do it by text message would be really, really interesting for us. There's a couple of like regulatory hurdles to address there. With texting being an opt-in instead of an opt-out, it's hard for us to really scale that up. The other issues, there's so many like opportunities. Like we're building a member app, and we're talking about having the HRAT live like natively within the member app. I think you hear about this in like consumer product trends all the time. Like you kind of got one part of the population that's aging, and we sort of have the outreach mechanisms for HRATs for them already. Over time, we're probably going to see less and less completions over phone, I think, as people frankly become less and less interested in talking on the phone to anybody. I don't think it's personal. It's just culturally where things are at. So doing things like texting app is going to become more important, and I think will help us capture a larger piece of the pie in terms of that 70% 40% parts of the population that aren't completing their HRAT or not completing it on time. So that's my presentation. I hope you guys learned something about Care Oregon's HRAT work. And I'm happy to take any questions. I don't know how we're doing on time, but I'll kick it back to you.
Got 15 minutes left, Care Oregon.
Okay. Thank you, Andrew. Let's see, next slide. Now, Mariah, our pharmacy senior manager, is going to talk a little bit about MedRec. And within Care Oregon, I think it might be in her slide too, we use the word proxy a lot, where we may have a measure or a program or a service that it might be intended for, let's say, medication adherence or MedRec, but we also take advantage and learn so much about our members that we call them proxies for, if we're identifying other characteristics about or social needs or I think different conditions that might not be documented or a claim has been submitted. So Mariah is really good at this. And so we look to her for, I think she just is very, comes up with so many innovative different ideas at Care Oregon, but that's why we use the word proxy, because we're often focusing on one thing, but we take advantage of the other data and information that we're collecting, and we try to weave that into our other programs or help us with data collection in other areas. So Mariah?
Thanks, Susan. That was really nice of you. Hi, everyone. Mariah Alford. I'm Senior Pharmacy Manager at Care Oregon. So we focus, my team, I have about 9 clinical pharmacists that work under me, working directly with our members on med reconciliation and a lot of other measures that we can talk about quickly. Next slide, please. So this is a proxy for care coordination, and Susan's right. We've gotten really good at this over the last 5 or so years that we've been working on it. We have a 5-star performance pretty consistently year to year now. We complete about 97% of all discharged Medicare members have a MedRec within 30 days of their hospital discharge. So we started just collecting that data, just getting the med reconciliation done, meeting sort of the minimum requirements for those med reconciliations to count for Medicare for this measure. But over time, what we discovered, and this is primarily feedback from my team, that there was a lot richer data set that we could really extrapolate from the medication reconciliation. So a lot of that was around PCP and member compatibility, capacity, hearing about capacity issues from our members in terms of being able to get in to see their care providers, looking at members' engagement in their with their PCP providers, getting in to see their providers with relative frequency and being engaged in those relationships. And then just broadly looking at the complexity of the conditions that our members face every day. So these are members, again, that have been hospitalized and are being discharged from a hospital facility, behavioral health or medical facility, and they have a lot of medical complexity. Typically, 3 or more conditions are being addressed at any given hospitalization. So whether or not that hospitalization is for heart failure, there's often ongoing issues with depression and other issues that are happening kind of simultaneously that the care teams are trying to address. So at MedRec post-discharge, you really have an opportunity to see what is happening in the hospital and then look back at the medical records from primary care visits leading up to that hospitalization to really evaluate whether the engagement and then the complexity of the member are really being addressed by that primary care provider. So We're also using this opportunity to look for additional care coordination barriers. DME, transportation is a huge one, and then food insecurity. We spend a lot of time on the phone with our members, making sure that they're maximizing the benefits, their use of the benefits that Care Oregon provides. So that includes their care card that has a quarterly benefit for groceries and over-the-counter medication products that we're not allowed to cover under the Medicare benefit. So really trying to coordinate their care, make sure that they're completing any incentives that we can with them over the phone. So that might be a check-in around medication adherence, or referring them for their annual HRA so that they can collect those benefit dollars, which is just more money that they can spend on food and utilities. The biggest barrier we have really in doing this is that the data systems that we have access to really don't support complete reporting of inpatient utilization. This is a particular barrier when it comes to behavioral health focused hospitalizations and systems. There's a lot of paper charting, a lot of claims showing up months later at the Care Oregon claims department, things that we don't hear about. And those are really just missed opportunities for us to be able to holistically evaluate our members post-discharge and then make sure that we're appropriately connecting them to all of their benefits and opportunities for care coordination. I talked about the incentive measures already, and then I'll just reiterate that the data is really the most important piece in enrolling members in these programs and making sure that we have the opportunity to care for them. So anytime that we are seeing a barrier in getting timely information around admission and discharge for our members is really just a missed opportunity for us to be able to focus in on that individual member and make sure that we're optimizing their PCP relationship, their overall benefits and coordination with the plan. That's all I have. If there are questions, I'm happy to answer. Great, thank you.
Thanks, Mariah. And I think we have one last piece, Janet. Okay. If I didn't mention before, I'm the Medicare STARS director. And then the next slide, please. Again, with the word proxy. So eye exams, we use eye exams to tell us a little bit more about what's going on in the network, and it's an opportunity to hear from our member. And so we have a 4-star performance in this area. And as long as I've been working in HEDIS and quality, it's always been with all health plans, it's always a struggle with data collection. I don't know that anyone's perfected it yet, but we have implemented a couple different things that's helping us. So one of the things that we look to our providers, again, back to the collaborative, sharing best practice. This is one of the incentive measures with our providers. So we learn a little bit about the need and and then access to getting into a specialty provider for the eye exam for diabetics, and the offering that we have provided to a couple different systems. We have retinal camera that we've co-located in a PCP setting so that the member does not need to leave that practice to go for a diabetic retinopathy exam. So that I know is best practice with other plans. I know that that's not quite new, but it was new to Care Oregon. So also thinking of other point of service opportunities, and that's what that is. We would like to see more providers take that on. I know that it's a workflow issue for some. We also talk to our providers, again, the balance that members do have a financial incentive also to fill this gap and receive this care. And we also have a value-based contract, not only with the provider, but we have a specialty network that we have an incentive for them for increasing member engagement strategies. And so they've worked with us to identify members that maybe presented 3 years ago, but they've not been back for their updated eye exam since. And so there's some, best practices emerging around this. And also what we have included in that specialty contract is incentives and language around data completeness and helping the health plan, helping us access data in a timely way for CMS performance measure fulfillment. And so I don't know if I have another slide here, Janet. Did I end with this? I think I did. So are there any questions about either the eye exam or different portions of the presentation today? Looks like George has one. George?
Yeah, what I've noticed was that when a person like me that goes in, gets an eye exam, or at least tries to, goes and finds out that the doctor won't accept certain insurances, and I end up having to go to another eye doctor. Some of the consumers don't, I'm not sure if it's at Care Oregon somewhere or we don't get a book as to which doctors that will take Medicare and Medicaid. And that's the confusing part on our side. We don't find out until we get it there to find out they won't take it. Is there a way that a booklet can come out from the eye department?
Well, George, oh, was I interrupting somebody else? Jenna, I thought I heard your voice.
Hello. Hi,
Hello.
So I can just speak for our plan, but we don't have vision insurance directly through us. So we use a third-party administrator called VSP, Vision Service Providers. So all of our materials kind of route to them so that the provider directory and everything goes through VSP directly. So kind of like, our best practice that we talk about is calling customer service, and they can help do like a warm transfer over to VSP to be able to give a selection of providers that are in the network.
Oh, okay. So there's no booklet that goes out?
No, there's not. Unfortunately, things like provider directories change pretty frequently. So we break everybody's mailboxes with that.
Okay. Thanks, Jenna.
Mm-hmm.
Thank you, George. I think we'll hand it back to you, Walter.
Thank you. Thank you, Care Oregon team. That was great. Really appreciate it. We are, we are 2 minutes ahead of schedule, which pretty much means we're on time. Great chat too, in our chat space, meeting chat space. It's public comment time, but I want to just take this second to really quickly kind of jump back up to the top. I apologize I was late. But I feel like just acknowledging to the group that last time I was with you, I was with a different carrier, and now I'm here at Care Oregon, just acknowledging the change. And I did hear Jake mention that Carolyn is not on our committee any longer. She has left Atrio. So that's our space. I just wanted to get that out into the open. So we are at the public comment space. Jake, I saw you pop up. Do you have something to say?
Just going to bring up, I don't know if you were, but if any CCOs or any individuals on here would like to, come on as Care Oregon has in this round, or Pacific Source in our previous round, and have a presentation they would like to share that would allow for collaboration and discussion, Care Oregon, again, thanks for all that you've shared today. I greatly appreciate it, as well as I'm sure many others do on this call. It was great to hear how other CCOs are working through some of the business that we have, and helping our members achieve the best healthcare possible. So if any other CCOs or groups would like to present in our November meeting, we would greatly appreciate it. Please reach out to Walter, myself, or Janet. If not, we'll definitely be reaching out to other CCOs to see if they can help take some reins.
Thanks, Jay. Yep, just a reminder, I know Janet mentioned it, we had discussed about 6 months back about sort of the context and agenda construction of our committee. And of course, we changed the name, but the sharing and collaboration of best practices is what's going to keep us healthy in this committee. So appreciate any carriers out there that want to share some best practices in whatever space, you feel like you're knocking it out of the park. And so thanks. Jay. All right, public comment time.
This is Christina with Trillium. I just wanted to say, thank you. I'm glad for this space. I think we're all trying to do the right work, and we're all using and working with the same providers. And it's like, how can we simplify the process for them? Because anything we can get a lift, especially from quality, it lifts the entire market. It's not like they're doing something different. We're all asking the same thing. So I think the more we can kind of work and share together best practices, the better off we'll be in the Oregon market. So just, thank you for this.
Yeah, thank you for the lovely comments, Stephen. George.
Yeah, I'm just kind of curious, out of curiosity, through all the CCOs, is all the CCOs working on the new project of people with any type of disability with providers?
George, could you go a little bit more in detail maybe on that?
Yeah, like going into the disability population and disability community and asking them what they actually need, what programs they want, what programs they need, the problems that they're having, and correcting the problem with providers.
I could say, and I think all of us are doing this, part of requirements, especially for the dual population when it comes to DSNP, is, you got the CAC that members are, engaged in, but also specific for having a DSNP advisory council. And I know, working at Trillium, that has been part of the questions that we have raised is about access for those members, making sure that they're able to connect with their doctors, have the conversations, getting in for needed appointments and things like that. And I think probably all of us are in that space right now on how we work, especially with a population that needs more of that access, maybe transportation needs, other medical needs that may be needed in that special population. I know that we are working on that. I don't know if that helps answer your question, George, but hearing from members is the most thing that are the value for us to understand, are we doing the right things and are we meeting the members where they're at? Because that's the most important thing is we can all talk as a group, but it's hearing from the members, are we satisfying that need and helping you bridge that gap with your provider or whatever needed services you may need?
And George, just to add on to Christina's comments, I think as CCOs or health organizations in general, our job is to make sure that we're doing the best for our members, especially in the space of the CCO or the DSNP membership. you know, it's definitely a different population than some other carriers may experience, and different type of needs. The DSNP advisory groups are a great call out by Christina, that were implemented, I think, across all CCOs. I think it was last year, or if you've had a DSNP for a while, you may have had one going prior. But I know I've sat in on those for our organization and received great feedback, and we've been able to take some action on some of it. But I think also our provider groups are constantly working with providers to ensure care is being, you know, managed in the right way is also, you know, as well.
Okay, I was just curious. Thanks.
George. Anybody else? It's 2:35. If we don't have any other comment, we can wrap it up and back to the contribution comments or requests. If there's anybody that would, any carriers that would like to share a best practice in the dual DSNP Medicare Medicaid space, you can reach out to Jake, Janet, or myself. Our next meeting is scheduled for November 12th, so there's a little bit of time to prepare. I think I have that right. That's what's on the agenda. But yeah, you can reach out to any one of the three of us, and we'll help you and make sure that we get you on the agenda. Okay. Well, last call. Jake, Janet, anything else to say? Anybody?
Just thanks, Walter, for jumping on, Janet for leading, and all the groups that participated today. Thank you.
Good meeting.
Thank you.
All right, everybody.
Thank you. Bye-bye.
Have a lovely afternoon.
Thanks, guys.